Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article 6 cycles of doxorubicin and cyclophosphamide or paclitaxel are not superior to 4 cycles as adjuvant chemotherapy for breast cancer in women with nil to 3 positive axillary nodes, CLGB 4T101, by Lawrence N. Schulman and his colleagues of the Cancer and Leukemia Group B. My name is Michael Gnant, and I am Professor of Surgery at the Comprehensive Cancer Center of the Medical University of Vienna in Vienna, Austria. The subject of this important article is adjuvant therapy for early breast cancer. We do know that despite appropriate local therapy, meaning surgery and radiotherapy if indicated, a proportion of patients suffer systemic recurrence of the disease during follow-up, indicating early spread and eventually causing disease progression and death. Overall, breast cancer recurrence rates have been greatly reduced in the last 3 decades by the implementation of adjuvant therapy using anti-hormonal therapies, cytotoxic treatment, and immunotherapy when indicated. Unfortunately, we do not know who will eventually relapse, and despite all scientific efforts, we still lack reliable predictive markers for post-surgical relapse. As a consequence, we nowadays recommend standard adjuvant therapy to all patients with certain prognostic subgroups, which inevitably leads to massive overtreatment of patients. Since adjuvant therapy, particularly adjuvant chemotherapy, carries significant side effects and quality of life impairments, it is of enormous value to determine on what the minimal intensity and duration of adjuvant chemotherapy is in order to achieve the intended relapse risk reduction in the adjuvant situation. In this context, the CLGB 4T101 study compared 4 cycles of adjuvant state-of-the-art chemotherapy with 6 cycles. Another question of this trial was to determine whether paclitaxel is equally efficacious as doxorubicin and cyclophosphamide, but this aspect is not discussed in the current publication. Overall, 3,171 breast cancer patients with node-negative disease or 1 to 3 involved lymph nodes were recruited between 2002 and 2008. Patients were stratified for ER, PGR, HER2, and menopausal status and received additional endocrine or trastuzumab therapy when appropriate. The primary result of the study shows that there is no difference between 4 cycles and 6 cycles of adjuvant chemotherapy, neither in the entire cohort nor in any pre-planned subgroup analysis. Initially, the study was powered to demonstrate a two-sided hazard reduction of 23% for relapse with 567 events in 4,646 patients. However, the study was monitored biannually by an independent Data and Safety Monitoring Board, and that DSMB released the data for the 4 versus 6 cycle comparison after 283 events in June 2010, indicating that even with further follow-up, the probability of a difference between the 2 arms would be extremely low. In fact, given the clear-cut similarity of the survival curves, the probability of a difference being demonstrated after the expected 567 events was as low as 0.001. There was also no difference in overall survival. In terms of toxicity and side effects, it is no surprise that grade 3 and 4 side effects were more common in the 6-cycle arm. For example, grade 3-4 neutropenia occurred in 34% of patients with 6 cycles of AC, but only in 26% of patients with 4 cycles. Grade 3 neuropathy occurred in 10% of patients with 6 cycles of paclitaxel versus 4% of patients with 4 cycles. Cardiac toxicity was more common in patients who received 6 cycles of AC. Although treatment-related deaths were extremely rare, 5 of them occurred in the 6-cycle arm versus only 2 in the 4-cycle arm. In summary, this huge trial demonstrates that in early breast cancer patients with negative nodes or limited nodal involvement, there is no benefit in delivering 6 cycles of adjuvant chemotherapy as compared to 4 cycles. The overall trial outcome is excellent, with just 115 confirmed breast cancer-related deaths in 3,171 patients and a calculated 8-year overall survival rate of about 90%. Limitations of this study that require mentioning include the somewhat premature closure, also reasonable on statistical grounds, and the fact that single-agent paclitaxel alone is currently not considered a standard adjuvant treatment, at least until that part of CLGB 4101 becomes available. However, there was no interaction between chemotherapy drugs used and the duration question. What do we make of this? The take-home message of this trial is in fact quite simple. More adjuvant chemotherapy is not better than appropriately dosed modern 4-cycle chemotherapy. Not even in the estrogen receptor negative subgroup, where one would assume that cytotoxic chemotherapy is most effective, the addition of 2 cycles of treatment demonstrated any additional benefit. With this information, 4 cycles of adjuvant chemotherapy should now be used as the standard of care for early breast cancer. An obvious question remains: how low can you go? With the conceptual difference of the adjuvant treatment situation compared, for example, with a neoadjuvant setting, where clearly more cycles provide better tumor shrinkage than less cycles, as shown by Steger et al. In the JCO publication from 2007, it is compelling to consider further reduction of side effects and toxicity by minimizing adjuvant chemotherapy further. Why would 4 cycles be optimal and not 3? The problem with questions like this is that given the overall reduced relapse rate, a trial addressing this would probably require 20,000 patients or more, and therefore may not be realistic. Also, adjuvant chemotherapy in principle is saving lives without doubt. And even if there is a price to pay for this in terms of toxicity, we must not compromise the great progress made in clinical breast cancer research by administering too few cycles of treatment. After all, it is reassuring that we can change the fate of our early breast cancer patients with an early and possibly brief intervention right after surgery. Finally, response prediction is nowadays becoming more important for clinical decision-making than risk assessment itself. The question who can safely be spared adjuvant cytotoxic treatment at all, not based on prognostic risk, but on individual predictive benefit, still remains unresolved. While we are on our way to answering this question, avoidance of unnecessary treatment should be one of the main goals in adjuvant breast oncology, and the authors have to be congratulated for achieving an important result that will be of benefit to our patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.